This procedure video will take you through the techniques of inserting a chest drain using a Seldinger technique. It is now becoming current practice that in most non-traumatic situations a Seldinger approach can be used for placing a chest drain. Again, as with all procedures, a formal introduction, a clear explanation, and the obtaining of verbal consent is always essential. Take some time now to familiarise yourself with the equipment shown above, and also to consider the indications for placing a chest drain. Take time to go back and look at the British Thoracic Society guidelines on chest drain placement for a pneumothorax.
Okay, so I'm going to find the anatomical marking for the insertion of a chest drain, and what I want to find is the triangle of safety, the base of which is at the level of the fifth rib, and I find the fifth rib by feeling for the angle, the sternal angle, feeling across and finding the second rib, and then down, third, fourth, fifth, and if you follow it around, it's usually around about the level in a man of the nipple. And for the insertion site of the chest drain, I want to go just anterior to the mid-axillary line. I'm going to clean the skin with some suitable antiseptic solution, chlorhexidine and alcohol mixture, and I'm going to clean a nice wide area. And then I'm going to drape the area to make it sterile. I'm going to recheck my position. Just anterior to the mid-axillary line, and then I'm going to infiltrate local anaesthetic, and I'm going to pierce the skin, aspirate to check I'm not in a vessel, and then infiltrate beneath the skin. And then I'm going to insert the needle down, aiming for the top of the rib. When I find the top of the rib, I'm going to just walk my way so I'm over the top of the rib, and then I'm going to aspirate and infiltrate all the way back, and the same again until I get all the way down to the pleura, and when I go through the pleura I should see it bubble, and then I can infiltrate all the way back up and make sure I've infiltrated with the local anaesthetic thoroughly. At this point I can leave the needle in situ just to leave my mark where I've infiltrated local anaesthetic. Remove that one, and then I'm going to insert my introducer needle into the same position, and I'm going to go down, feeling for the rib and trying to aim the needle just over the top of the rib, avoiding the neurovascular bundle in the rib above, aspirating as I go in until I hit the pleural space and get free aspiration of air. I'm going to remove my syringe,